Community-based approaches to mental health and psychosocial support work with affected communities to enable them to care for and support their members. They involve the community in all stages of the response, from assessment and planning to implementation and evaluation. In June 2020, the Working Group on Community-Based MHPSS of the IASC Reference Group on MHPSS held an online discussion with practitioners from around the world to reflect on how they dealt with the challenges of supporting communities that were facing grief, loss, and disruption of their usual rituals due to the COVID-19 pandemic.
The pandemic has disrupted the way that people are able to grieve both COVID-19 related deaths and others. Because of precautions against the spread of the virus, people have not been able to gather to support each other in grief, to attend funerals of loved ones, or to perform the rituals owed to those died. To help communities cope with this, we needed to understand what was being disrupted, how it was affecting people, and what resources they had to adapt and respond. We learned how important this was during the Ebola outbreak, and those lessons guide us during the pandemic.
Yes, we needed to talk to community members to understand the challenges created by the pandemic to the customary forms of grieving. We spoke to diverse people, including religious leaders, women, marginalized groups, older people, and youth, to get their perspectives. We discussed the different types of rituals or remembrances in their community and asked them how these could be adapted to be safe during the pandemic. However, there were sometimes variation in practices between regions of the same country or even within the same community.
Starting a community-based dialogue at all levels about this, including with the health staff and officials responsible for ensuring safety, really helped. This dialogue offered deeper insights into the steps and meanings of funeral rituals. This understanding helped them to devise and agree acceptable adaptations that kept the communities safe during the pandemic, but still gave them a meaningful way to mourn.
We brought the decision makers and representatives of communities together to identify what support was required to enable these alternatives to be successful and strategize how to mobilize resources.
We asked communities to think about who might be especially vulnerable after a death and what could be done to help them. Community members were able to identify practical actions and plan ways they could put these into practice.
In the Bahamas, working with community leaders, it was identified that follow-up support was needed to help people cope with loss, so virtual groups were established. This was not only for those suffering losses during the pandemic, but also for those affected by the hurricane last year. It's so important not to forget pre-existing losses and vulnerabilities.
Through dialogue with health officials, religious leaders came up with ways to adapt the customary washing and burial rituals to be safe for those handling the body. Likewise, the healthcare and mortuary workers were guided in how to communicate with and prepare the bereaved family for adapted last rites under the COVID-19 precautions.
In Iraq, social media was used to suggest ways that people could observe symbolic rituals and to give information on how to access psychosocial and mental health services if needed. Case managers provided remote support, and individuals were able to access one-on-one counseling. Technology has been really helpful to connect to people for support.
It didn't work so easily everywhere. Where I worked, it was very challenging to mobilize people and provide support remotely in places where there was poor internet or phone connectivity. Also, the stigma and fear around COVID-19 sometimes made it hard to mobilize people to support bereaved families or individuals. This was very sad to see.
We need to keep talking to community members, including those who are marginalized and especially vulnerable, to get feedback on how the support is working for them. Doing this regularly and systematically can help to identify gaps or weaknesses. We involve community members in devising solutions, using their experience and community resources, and adding our technical knowledge to the mix.
We added new indicators to our usual monitoring and evaluation system to make sure that we were measuring the impacts that were important to community members. This meant our results better reflected new priorities during COVID-19.
It's so important that the approaches we developed can be sustained by the community when external supports are no longer present. For this, we have to genuinely share implementation and decision-making with members of the community. The MHPSS activities have to be based on research they will continue to have after our project is over.
We emphasized capacity building not just in terms of skills training, but also giving people opportunities to take on and grow into new roles. Once community members own these processes, they need us less and less.
But sustainability is one of the hardest things to achieve. It's not something we can think about at the end of a process. We need to think about integrating activities into pre-existing structures, systems, traditions, and roles from the very outset. People may not initially believe that we want to work collaboratively with them, but we need to prove we are committed to the ownership of the process.
The practitioners participating in the discussion on community-based approaches to MHPSS in the context of grief, loss, and disrupted rituals did not understate the challenges of doing this work during the pandemic. However, they all affirmed the importance of engagement and working with and through communities. For more information about community-based approaches to MHPSS, see the guidance note from the IASC MHPSS reference group. You can find this resource and connect with other practitioners at MHPSS.net.